Wonderful. Well, I'm Danielle Hessler-Jones. I'm one of the co-directors of SIREN, the Social Interventions Research and Evaluation Network, and it is my pleasure to welcome you here today for our next hot topic discussion. And so this is actually part one of a two-part webinar series entitled Lessons from the Intimate Partner Violence Field, Moving Beyond Surveillance and Screening Towards Safety and Wellbeing. And here we're so excited to have some experts here with us today and for our second session, where we're going to be learning from them in the intimate partner violence field. They have spent decades designing and redesigning strategies to promote violence prevention and healing. And so here today in part one of the series, our presenters are going to be discussing the intersection between intimate partner violence and other social drivers of health, evidence-based and healing-centered approaches for responding to intimate partner violence, and strategies that have been shown to enable and sustain meaningful partnerships with community-based organizations. And then next month, on December 3rd, we're going to welcome our presenters back, and we're going to continue this discussion, focusing on confronting current challenges, such as reporting requirements and privacy and safety considerations, as well as recommendations for documentation, coding, and system changes, focused on creating sustainable and equitable data collection and responses. And in just a moment here, I'm going to be putting here into the chat a link where you can register for part two of the webinar if you haven't already had a chance to do so. Next. Before we go any further, I want to acknowledge our gratitude and many, many heartfelt thanks to Blue Shield of California Foundation for making this webinar and this two-part series possible with their funding. Next. And to welcome our outstanding panelists that you are going to be hearing from today. So Dr. Elizabeth Miller is a distinguished professor of pediatrics and public health at the University of Pittsburgh School of Medicine, a physician in adolescent and young adult medicine, and medical director of community health at UPMC Children's Hospital of Pittsburgh. Trained in internal medicine, pediatrics, and medical anthropology, she has spent over 20 years of practice and community-partnered research, addressing interpersonal violence prevention among adolescents and young adults in clinical and community settings. And Lisa James. Lisa James is Vice President of Health at Futures Without Violence. As part of a national health initiative on domestic violence during her 20-plus years at Futures Without Violence, she has collaborated with healthcare providers, domestic violence experts, and health policymakers in over 25 states across the U.S. to develop statewide healthcare responses to domestic violence through training, health policy reform, and public education. Next. Before we get to hear from these amazing panelists and dive in, I do have the task and responsibility of sharing just a couple webinar logistics with you. This webinar is being recorded. We will send a link to the recording to all registered participants when it's available. We also do welcome your questions during the webinar. We welcome and vigorously encourage them. So please use that Q&A function that you'll see on the Zoom. You won't be able to send chats. You'll be able to see chats, but not send them. So please post your questions in the Q&A feature. Next. And last, before I hand over the virtual mic, we just wanted to give a quick announcement that our registration for our SIREN National Research Meeting is officially open. So whether or not you're hearing it for the first time or the second or fifth time, registration officially open. You can go to the website there to check out all the details, and we very much hope to see many of you in San Diego in February. And with that, I'm now so honored that Liz and Lisa have agreed to spend this time with us, and let me hand it over to you so we can learn from you. Thank you.
You. Thank you so much. It's such a pleasure to be here. I'm a big fan of the SIREN network and all of the work that you all do, following it very regularly. So it's pleased to have some time to be together for these two sessions. As was mentioned, I'm with Futures Without Violence. We're based in the Presidio in San Francisco, but we're national, and we've been working as a health and social justice nonprofit for almost 40 years to heal those who are traumatized by violence and trauma and to promote prevention. Next slide. We are a multi-sectoral organization, so we do work in lots of different sectors, but my work is with the National Health Initiative. And so we are home to the National Health Resource Center on Domestic Violence. We've been funded for over 30 years by the Family Violence Prevention and Services programs who support improved responses and prevention in the health and public health arenas. Next slide, please. Also, more recently, in the last 5 years or so, we've been identified by HRSA, Health Resources and Services Administration, to lead the Health Partners on Intimate Partner Violence and Exploitation, which is a national technical assistance and training center specifically for community health centers and the Community Health Center Network here in the US. Next slide, please. All of that, just to say, in terms of the resource centers, I just want to lift up. The reason that I bring them up is it's because through both of those efforts, we can provide training, technical assistance, and resources, and that's both available to you as the field, but also when we learn from you as the field, we implement it and integrate that into our national technical assistance centers. Next slide, please. I want to just take a quick moment to ground us in kind of why we do the work and make sure we're level setting about what we're talking about when we talk about intimate partner violence. We're really talking about a relationship where there's a pattern of abusive and controlling behaviors really designed to maintain power and control over another person. So it's not necessarily a one-time incident, and it's not only physical violence. It can also be controlling behaviors that use jealousy, mental health coercion, economic coercion, and other kinds of controlling and isolating behaviors. And it's always critical to lift up that sometimes leaving an abusive relationship might not always be the most realistic or safe options for survivors. So we work to offer resources, options, and help them safety plan as much as possible and really lead by what the survivor chooses to do. Next slide, please. Unfortunately, intimate partner violence and sexual violence are much more prevalent than many people understand. These are some of the latest studies and stats out of the CDC, with 1 in 2 women and 2 in 5 men experiencing intimate partner violence, and 1 in 3 women and 1 in 4 men experiencing sexual violence. And we know that because of those intersecting forms of racism and sexism and trans and homophobia and other forms of oppression, oftentimes marginalized communities are experiencing violence and trauma at higher rates. So this is definitely something that's impacting our communities across the country. Next slide, please. And the reason that we have been partnering with the Family Violence Prevention and Services Program and with HRSA and with others, such as the Blue Shield of California Foundation, to really lift up the role of healthcare providers is because that we know violence has such significant and long-lasting impact on health. So it's much more than the injuries themselves. I think when I started doing this work so many years ago, we were focused primarily on injuries. But over the years and decades, we've really learned a lot more about the significant long-term chronic health issues that are associated with exposure to violence. And some of the leading health issues that we're challenged by in our country are really linked to intimate partner violence, as you see here on the screen. So in addition to some of those chronic health issues, we also see significant impact on behavioral health conditions such as depression and anxiety and PTSD. And so it's because of this that we know we've got to start to get under a better response in a healthcare setting so that we can improve these health outcomes and promote prevention. Next slide, please. Um, and we also know that intimate partner violence is really a key social driver of health. It's one of the few that has a U.S. Preventive Services Task Force recommendation of a B to identify and respond. And so that's really due to, again, the kind of decades of work in the field. But we also know that it contributes to other social drivers of health. We know a significant proportion of homeless folks have experienced violence, definitely contributes to job and food insecurity. And the isolation that so many survivors experience is a key component in interrupting social connectedness that we know is so critical for improved behavioral and mental health. At the same time, the flip side is true. So when we address the social needs like food insecurity and economic supports and housing, we can also prevent intimate partner violence. And that's why we're so happy to be here with you today and during our next session to talk a little bit about how those intersections can really feed and complement one another's work. Next slide, please. Next slide. I lift up that the U.S. Preventive Services Task Force recommends a response to intimate partner violence, and that has really come from the decades of work that we've been doing for so long to try and improve the healthcare response to violence and improve identification. And with those lessons, we made a lot of mistakes, frankly, and have learned a lot through how we can tinker with and improve the way in which we respond to intimate partner violence in the healthcare arena. And one of the items that we noticed is that our screening, when we implement screening, even when it's implemented by the most caring and compassionate providers, we are not seeing anywhere near the disclosure rates that we know are on par with the prevalence rates that I was just sharing. And we also came to the realization that because of that, the resources that are so critical in creating safety and supports are only being offered to those patients who choose to disclose that they are experiencing violence. And so that there's a real missed opportunity for prevention education. And we're going to talk a little bit about how we've adapted some of the approaches based on that. And I think it's applicable to other social interventions as well. Next slide, please. We, again, are just sort of sharing what we learned as we started to implement, and we're so proud of the work that we were doing to implement and are doing to implement improved conversations, assessment, and response with intimate partner violence. But we did see that the screening tools that were being used were really being implemented in ways that aren't necessarily supportive to survivors. And so these are true examples from the field. With people being asked about whether or not they're being heard at home in front of a partner, where people are being asked about whether or not they've ever been hit, kicked, or slapped with the nurse or provider having their back to the person and looking at the computer screen. And really apologizing for some of the questions that are needing to be asked. And all of these, whether intentional or not, sort of set the tone for not inviting a disclosure or response, and definitely not creating a healing-centered environment in which to have conversations about something so sensitive as intimate partner violence. Next slide, please. We also have heard from survivors over the years about what they want from healthcare providers, and they really say that they want autonomy, empathy, and informed providers. And so they want to be able to make their own decisions when it comes to healthcare, including choosing whether or not to disclose what they're going through. If they do disclose, they want empathy and compassion and non-judgmental support, regardless of how they receive any recommendations or interventions from healthcare providers. And they want to make sure that the providers they're working with understand what they're going through and where to get help. And so again, I would say each of these are really principles that we apply to responding to any social driver of health, and are lessons learned that can carry over for all of your social interventions. Next slide, please. So with that, I'm going to turn it over to Dr. Miller to talk a little bit about how we've adapted interventions for intimate partner violence based on those learnings and how they might have implications for other social interventions as well. Next slide.
Beautiful, Lisa. Thank you, thank you, thank you. And what an honor and privilege to be here with you all today. As Lisa was saying, right, the opportunity to present to you all within the SIREN network is extraordinary because you are really on the front lines of thinking about health system innovation, but also this concept of social care, which I just am so grateful that your upcoming conference is focused on the science of social care. And I hope that some of the nuggets of what we sort of talking about today resonate with you. Before I move forward, though, and Lisa, feel free to jump in here too. There was a wonderful question about what's the difference between intimate partner violence and domestic violence. And so some of that is historic in that when I started in this field as a wee medical student way back in the 80s, the focus very much was on domestic violence, meaning violence that was occurring in the home, often invisible to many of us. And so this concept of just thinking about sort of the other terms that were used often were like spousal abuse, spousal violence, domestic violence. The shift that happened in language around to expand to intimate partner violence was a recognition that intimate partners don't necessarily live in the same home, yet the physical, sexual, emotional abuse that Lisa described indeed covers or that range. And so that it was not just the four walls of a home that defines intimate partner violence, could also include ex-spouses, ex-partners, and others with whom one had been in a relationship. And interestingly, as there has been more interest in the impact of childhood adversities and toxic stress on health, the term now domestic violence has really come to encompass in the violence prevention field kind of a range of violence occurring in the home, including parents to children, children to parents, and sibling related violence as well. And so there's been this sort of interest shift in language, at least within the violence prevention field. But there are also some things that don't change in the federal government, which is the ways in which we talk about funding to victim service agencies that are domestic violence agencies, even though their focus is primarily intimate partner violence prevention, as well as the prevention of ongoing childhood adversity for those survivors with children. Lisa, what else would you add in terms of definition?
I think that's great. And that oftentimes you'll see that we use intimate partner violence and domestic violence sort of interchangeably, and that each of the strategies that we lift up today really can be applied for all forms of violence and trauma, as well as adversity. So just keep that in mind as well. Thanks, Liz.
Really beautiful. Thank you. Thank you. So, as Lisa was really underscoring, what we have learned over the years is that screening for domestic violence looks, feels, and has results distinctly different from screening, for example, for cervical cancer. And that unlike screening for cervical cancer with a pap smear and being able to remove atypical cells and prevent cervical cancer, we have all, I think, come to appreciate that violence and trauma are much more complex, that the ways that there is no simple solution to swooping in and extracting, those atypical cells, right? There is no extracting in a sort of, with all of the challenges that represents. And back in the 80s and 90s, as we were really trying to draw attention to the challenges of intimate partner violence, how often we were missing this in the healthcare field, but also how much intimate partner violence was impacting our ability to provide care, that we really thought at the time that screening was the right paradigm. And over the last 2 decades now, with lots and lots of listening with survivors and practitioners in the field, have come to understand that there are many, many reasons that our patients are not coming into our offices saying, "Hi, I'm in an abusive relationship and I need help." Right? In fact, in my 30 years as a clinician, it has never happened to me. And that in fact, the screening questions sometimes can feel very dehumanizing to a number of our patients and very scary, with the potential for a carceral response, such as child welfare or law enforcement involvement in their lives. And so, over the last 2 decades, in really wonderful collaboration with Futures Without Violence, we have been developing and testing an approach called universal education, which is rather than waiting for a patient to say yes to a screening question, that we offer the resources, the education to all of our patients. And this really underscores what Lisa was sharing earlier, which is the prevalence of intimate partner violence in the healthcare in healthcare settings is very, very high. And so offering universal education we have a very high likelihood of reaching survivors, and gives us an opportunity as clinicians to offer this information about making the connection between violence, health, and their health risks. So next slide. We have simplified this, and I don't have time today to go through all of the background in terms of the research on this, but have really distilled this brief evidence-based intervention into 4 components: C for confidentiality, U for universal education, E for empowerment, and S for support. And why the very first part about confidentiality is so important is I was actually just giving a similar presentation just last week, and the number of people in the room who put up their hands, and when I asked, how many of you have been screened with your partner or another family member in the room? And huge number of people put their hand up, right? Because so often we're doing the screening, even talking about intimate partner violence, without attention to privacy and confidentiality. So the next slide is what survivors have said about the limits of confidentiality. So this is coming from our National Domestic Violence Hotline survey with survivors, finding that 60% of participants said that the fear of reporting changed what they decided to share, right? Really worried about breach of confidentiality. I stopped going to my doctor's office. I talk to no one. There's no one I can trust, no one I can turn to. I just keep everything to myself. The formal report was made without my being on board. It could be a report, a mandated report. Some states do require reporting for domestic violence, or it could be related to Child Protective Services. But I felt helpless, as though my situation had been labeled for me before I could come to any conclusion myself. Police and CPS, Child Protective Services, did nothing, and the abuser went on a rampage against us. And so next, as Danielle was sharing, December 3rd, we will be coming back to talk much more about the systems changes that need to happen to ensure that we can do this work with privacy, confidentiality, kind of front and center efforts to really keep our documentation really good, but at the same time, being able to manage the privacy and confidentiality. So next slide, to just briefly kind of summarize the Q's intervention. C is for confidentiality. We always see patients alone. And one of the things from a systems perspective is making absolutely sure that we do have policy within our healthcare delivery systems, ensuring that we bring up discussion about relationships and violence and stress safely by seeing patients alone. and then talking about those limits of confidentiality. And I will offer some resources with you. I understand some people don't want to share certain things about their health or relationships. I want you to know you can use any resources I give you for yourself or for a friend, regardless of what you choose to share with me today. And that we really, really take to heart survivors saying, please don't push for disclosure, right? We'll tell you when we're ready. And so this is really an aspect we think in responding to any social driver of health, or working with anyone who may be concerned about privacy, fear, or systems involvement. And so, very concretely, what this means is if there's already a system, for example, of asking in practice about food security, recognizing that perhaps in a pediatric practice with a parent who has 3 children there, the likelihood that they would disclose that they're worried about putting food on the table for fear of Child Protective Services getting involved. So that's what we're talking about in terms of establishing confidentiality and offering these resources up front. And so the next slide gets to the universal education and the empowerment part. So next slide, which gets to a bit of a script here, but I've started giving 2 of these cards to all of my patients in case you're ever struggling in a relationship or if you feel like someone's taking advantage of you. Also, so you have this information to help a friend or family member. And what we have found, this aspect of this information may be relevant for you. I'm certain it's going to be relevant for somebody that you know. We have found in both our research as well as from practitioners how incredibly important that aspect of offering universal education so you can help others. And we encourage people to open up the educational card, kind of go through it, ensuring that patients don't have to answer yes to a screening question. They don't have to disclose in order to receive the information, and can be really, again, applied to all social interventions to promote peer-to-peer education. Next slide. So an example of this, these educational cards, and Lisa will be sharing with you at the end also how to get, these educational cards available, but they really are about making the connection between intimate partner violence and health, as well as harm reduction strategies, which I'll talk about in a moment. And then next slide, and we'll touch on today about partnership development. And what we can do within our healthcare delivery systems to ensure that we have stronger cross-sector collaboration. The S for the Q's intervention is a reminder about support, right? Even though we're saying don't force people to disclose, it actually turns out we have found in our research that as you do this more universal education approach, amazingly, patients feel much more comfortable and will often lean in and share some information. So we really need to know how to support someone who discloses. And so in the next slide, we're going to talk in a moment about making a warm referral to a local domestic or sexual violence partner agency or national hotlines and so forth. But most important, what survivors say they want us as clinicians to do is to validate their experience. I really think about this as how grateful I am, right, that my patient chose me to share their story with. And I'm, always like very much, I'm so grateful that you shared that with me. And thank you for trusting me with your story. And then our obligation within the healthcare system to make sure that all of our clinical team is prepared with this next script, which is I work with a program that we trust, right? We've got a relationship. They understand complicated relationships, and we can make that connection together. I suspect that many of you are very familiar with SBIRT, right? The substance use brief intervention and response approach. This warm referral, right, is this very same to what we train people to do with SBIRT, is make that warm referral as, right, we don't need to be able to do all of the safety planning. What we need to know is how to make that connection to experts who do. And what we would like to suggest is that offering those health promotion strategies and a care plan, right, that takes surviving abuse or any social need into consideration is really useful for people who are facing really complex social drivers of health. So then next slide is just to spend a little bit of time talking about health promotion and harm reduction, because I think it's really hard sometimes for us to wrap our head around what's harm reduction for intimate partner violence look like. So next slide. Um, for all right social drivers and interventions, that we really think about shifting from this emphasis on screening, case identification, referral, right, but understanding that because risk stratification can be so limited due to the multiple pressures on our patients and families on disclosure, that offering universal resource, those resources universally, and then measuring uptake or need in the community with our partners is really one way to actually measure how strong these partnerships can be. And we can really do some kind of action at the point of care, right, in that clinical moment. So, how can we adjust, right? Not just adding more questions to a screening form, but also how can we adjust our care plan so that it's not just a unidirectional referral, like here's a hotline number, but in fact, how do we do systems integration in this space? And I think one of the most exciting things for me with working in the field of social care and this great emphasis happening now around social drivers of health is that we can actually push for good systems integration, including strategies for ensuring that some reimbursement goes to our community partners to be able to help support our patients. So next slide. I just want to sort of touch on a few places and just plant some seeds. And we may come back to this in the questions also, but there are aspects of intimate partner violence where we have the opportunity to do immediate, right, support for patients. So one example of this is reproductive coercion, which is a phenomena where abusive partners will sabotage contraception, may manipulate condoms, may force a partner to get an abortion or prevent them from getting one, may you withhold money, finances needed to purchase contraception, or threatening the pregnant person if they don't follow their wishes, right? So there's this phenomenon of reproductive coercion, which over many years we have worked with family planning, Title X providers to say, recognize, offer information about reproductive coercion. The harm reduction strategy is to be able to actually offer contraception that a partner cannot interfere with. Another example, oh, I'm sorry, I missed on the next slide. We actually list some of the harm reduction, which is like offering birth control that's less prone to interference or removing birth control out of the packaging if a partner is actually monitoring their medication. So there's many more tools, but that's what we mean by doing harm reduction right in the moment. Another example of this next slide is in mental health, where we find, and this is, I think, really eye-opening for those providing behavioral health, is the extent to which intimate partner violence results in a lot of gaslighting and many survivors being told by their partner that they're crazy and that their partner deliberately did things to make them feel like they were losing their mind. So this mental health coercion is another place where we can make that connection between why is this patient coming in for depression, anxiety, and substance use treatment, and could intimate partner violence be part of their story? Next slide. In terms of harm reduction, then, right, are recognizing that partners interfere with people getting care. So strategies can include keeping appointments and helping them stay connected to services if their abuser, right, is if the person who's using abuse is using tactics that prevent them from getting care. And this has, often sort of included ways of working with our front desk staff to really help our patients like find ways to like stagger their appointment times, considering alternative ways to meet. We can really, really help our patients who are experiencing this kind of abuse. And then finally, next slide, for those on the call who are engaged in substance use treatment, substance use coercion also is quite common. Survivors reporting that over 1 in 4 the partners had used that they had used substances to reduce the pain of experiencing partner violence, and a similar proportion had been pressured or forced to use substances or made to use more than they wanted. And so much more to say about this, but the next slide, again, highlighting what we can do in terms of harm reduction, is thinking about some ways in just bringing this up with our patients. People have shared with us that their partner, ex-partner, pressured them to use substances, use in ways they didn't want to, use their substance use as a way to control them. And like if you can relate to any of this, know that we're here to help, and that we are in the moment able to offer again a range of harm reduction strategies. And so really hoping that this really sets the stage for thinking about ways in which we can reframe our role in the healthcare delivery system. So Lisa, back to you.
Thank you, Dr. Miller. I want to lift up a couple of things before I move to building and sustaining partnerships, and that is that the work around mental health coercion and substance use coercion is being led by a group called the Domestic Violence, Trauma and Mental Health Resource Center, and they do amazing work. I'll link to some of their resources at the end here, but they're really fine-tuning and testing some of these assessment and response strategies, and the conversation starters and the harm reduction approaches for all of those types of coercion, birth control coercion, reproductive coercion that Dr. Miller talked about, mental health and substance use. I think offer us a window into thinking about how can this be applied to other efforts around social care. And how do we want to think through, as the screening forms become longer and longer, how do we want to think through offering strategies to have conversations about these topics, to link them up with one another, because we know the patients and clients we're seeing are oftentimes experiencing multiple social needs. And so how can we make those connections, acknowledge the connections, and offer some resources before we offer a referral? It's because we know that many people might not be ready to take a referral right then and there. So we have this amazing opportunity to offer some support right then and there. So definitely welcome ideas around how to develop other health promotion, harm reduction strategies, or promote those that you're using in the social care space for other issues as well. I also wanted to make one comment, and that is, while we've been really understanding how universal education can help us provide resources to as many people as possible, regardless of disclosure, we recognize that many of our programs that we partner with are already screening. They might be using a prepare form, and they might be asking about domestic violence on the prepare form. They might have hits or embedded into their electronic health record. It's fairly advanced in the field to have some kind of screening in place. And so if that's the case, we would just strongly recommend that you combine universal education with screening and use it as a bridge to really lift up that. Sometimes you offer the universal education and then turn to the screening form and set the stage by saying many times people find it helpful to reflect on some of these questions. So I'm going to ask you some of these questions, but then again, really reinforcing that you can choose how you want it to disclose. So I wanted to just lift up those key points before turning to building partnerships. Next slide, please. Dr. Miller talked a little bit about a warm referral and how it's used in multiple issues, as you know, in terms of making a referral to other services. But I did want to take a moment to acknowledge how intimate partner violence referrals might be a little bit different, or at least we should lift up what what anti-violence programs do, because they really can be key members of the care team. They not only offer crisis safety planning, but they also help with transitional, both emergency and transitional housing. They provide legal advocacy, and they do court accompaniment. They help with immigration legal issues. They help folks get jobs. They definitely lead and facilitate peer support groups and counseling. They can offer, depending on the program, can offer services for children who've been growing up in families where there have been violence, and so there's a really important opportunity to support the children. And so this is just a short list of all the things that anti-violence programs can do. And so when you make that, when a provider makes that warm referral, or when a researcher is looking at the impact of these types of interventions, we really want to lift up the strengths of the anti-violence programs that are in most communities across the country. Next slide. And just lifting up that that's really the heart of the model that we at Futures Without Violence have been implementing for decades. This is a model specific to community health centers, but it really is for any healthcare program to not only build that partnership between the health center making a referral to a domestic violence program if needed, but also we do extensive work with anti-violence programs to talk with them about the health impact of violence, and how they can play a role in some initial health assessments, and play that report, that sort of bi-directional referral back to a health center, and help get them enrolled, help them find a health home and for themselves and their children if they have them. Next slide, please. We have a number of tools and resources that can help build these meaningful partnerships. On the last slide, that infographic, we have sample memorandums of understanding of what it might look like to build a meaningful partnership. In this case with community-based domestic violence programs, but I really think these are elements that can apply to any meaningful partnership with CBOs that are supporting your work responding to social care. So again, teams don't have to start from scratch. There are a lot of lessons learned over the decades of what it takes to build and maintain meaningful partnerships and really see the CBO as part of the care team. And so that includes understanding what the local resources are, what languages are they providing and offering, how do you, what transportation, how does a person get there? Really identifying champions both on your own healthcare team and at the domestic violence programs that can stay abreast of the collaboration and setting clear goals for the collaboration. Then in developing a plan, if somebody's to implement a program where you might meet and talk regularly, be it monthly or quarterly. And I can't stress enough some kind of cross training. We do speak different languages from one another, and so it's important to understand what our shared goals are, and training on what resources are available. And we've seen some very just beautiful collaborations across the country when we do this work, where that kind of bi-directional referral can be so meaningful for survivors and their family, including some creative strategies around getting survivors in a sort of a backdoor appointment if they need immediate support, to all the way to having a co-location of either a healthcare provider at a domestic violence program or an advocate co-located at a healthcare system. So a whole host of resources that are available here in those links around building partnerships. And we'll talk next time in our next session about some of the challenges there, because it's not all rosy and easy. There's a lot of challenges as we build these meaningful partnerships, particularly coming up around data sharing, confidentiality requirements, how to navigate social referral platforms and what have you. So there's a lot of thinking going on in the field, which we'll lift up at our next session. Next slide, please. I did want to just, I know Dr. Miller said we don't have time to go through all of the data, but I did want to just lift up the value of this kind of approach and acknowledge that in the paper that's linked here on this slide, we go through the data more robustly, but that when we offer universal education and empowerment and some of these harm reduction health promotion strategies, we are seeing significant improvements for patients and for providers and around peer-to-peer education. We talked a little bit about reproductive coercion, and one such study that Dr. Miller led found that when a universal education and empowerment approach was implemented in a reproductive health setting, it was associated with a 71% reduction in pregnancy pressure. And those women, and in this case, they were primarily women, reported who received the intervention reported 60% that they were 60% more likely to end a relationship because they felt it was unsafe, which was not actually the goal of the intervention, but it was an interesting finding. Additional research looking at universal education models have also demonstrated that actually, even though disclosure isn't the goal, we see a threefold increase in disclosure among young people who experience abuse, and as well as they report decreased isolation and reproductive coercion if they had high levels of reproductive coercion going into the study before the intervention. So again, when you build that trust, you can really start to get a little bit closer to our goal of identifying folks who need support and offering those resources that promote peer-to-peer education. When patients do receive this type of intervention and resource, they are more likely, twice as likely, to share the resources with friends and family members. So when we shift that paradigm from I've got the resources and if you tell me what you're experiencing, I will give it to you, to can you be my partner in public health? Will you share this information with friends and family? Then we really see that can be impactful. Next slide, please. I know I want to give some time for questions, so I'm just going to zip through these resources to let you know, next slide, what we have available. We have the paper that was mentioned around try to apply some of these lessons learned to other social determinants or drivers of health. Next slide. And you'll get these slides, so I'm sorry, I'm just going so quickly. We have a number of population and setting specific resources, patient safety cards that we lifted up in the intervention that are in multiple languages. Next slide. We have an online toolkit that you can go to understand all the aspects of this type of intervention. Next slide. And we have a number of different tools like protocols and MOUs that you can borrow and use and adapt as needed. Next slide. As well as some specific toolkits for intersections, such as those between intimate partner violence, homelessness, and behavioral health. Next slide. And I talked about the National Center for Domestic Violence, Trauma, and Mental Health. This is some of their resources. They do amazing work, so I definitely suggest you check them out. Next slide. And I also have a conference pitch. We are hosting our conference on health, and so I want to invite you, those of you who are doing creative work around health and violence and trauma, please submit and attend. It's coming up in next year in San Francisco in September. Next slide. And I'm going to hold on this because I know I only have 5 minutes, but I did want to say that I do encourage you to take a look at some of these interventions, and also to note that the Women's Preventive Health Task Force is currently encouraging comments around their recommendations for intimate partner violence. And so here's a link, and we encourage you to take a look. We are definitely going to be making comments that they include universal education into their approaches and lift up some of that data, as well as some other recommendations. So anybody who would like to talk more about that, please reach out. And I really look forward to our next session where we can talk about some of these tricky issues around documentation, coding, privacy, and data sharing. as well as some really promising opportunities and models from other states that are really leveraging Medicaid for intimate partner violence interventions. Whew, that was a lot of resources, but we have more. Please don't hesitate to reach out if you want to talk them through. We have a few minutes for questions and comments.
Thank you so much to you both for that amazing presentation. And this is only part one of two. So again, thank you everyone for tuning in. We have a few minutes for questions today, and then part two will continue this conversation where we'll have a chance for additional conversation. Dr. Miller is actively answering questions in the chat as we go, which has been fabulous. There's one here that I was gonna lift up from Laura Gottlieb. In thinking about everything that you've presented here today about providing resources universally, and then thinking about what's going on, in terms of mandates around screening. I wonder, what are your recommendations regarding IPV for quality measures in light of the universal education strategy? And do you think it should apply to all social context variables or only IPV?
Liz, you want to go? You want me to go first? Okay. I mean, I'm interested in the quality measures that look at whether or not universal education assessments and response are offered. It can be, as I said, it can be a universal education plus screening. It can be looking at universal education alone. It can definitely be looking at whether or not, if somebody does disclose, are they offered supportive and support and validation, as well as referrals, and some of those harm reduction strategies, are those integrated? So I guess it's a mixed message, really, but it's also one that looks at more than just, are they being screened and do they have a straight up a referral, without any understanding about whether or not they can take that up. And Dr. Miller, I don't know if you have anything more to add about that.
No, indeed. And I think that it is really important for all of us to be advocating, right, for using those intimate partner violence related codes that are, they're specifically IPV counseling codes. We do, in my adolescent young adult medicine clinic, because we all routinely do universal education, we are actually billing Title X for IPV counseling for every visit, right? And so it is absolutely, depending on the setting and so forth, right? It is there, and universal education absolutely fits the bill for doing, IPV counseling. And so, I do think there are ways for us to continue to say this is really, really important, and that screening may not always be the right strategy, in particular for our patients who've been made vulnerable by such profound, right, structural inequities.
And you lift up the codes, and I'll just say we will spend some time. We've done some pretty deep work with the Gravity Project around some of those intervention codes. And so we'll definitely be lifting those up at our next session.
Fantastic. And then I'm sneaking in one last question before the top of the hour. And again, thank you for already responding in the chat. A couple of folks have asked the same question in a few different ways of, where to start, and the real world tension of bringing this great information in. And besides what's already been shared of starting with staff and how IPV has impacted them, anything else that you would like to close with of how we can make a difference and start?
I'm glad I didn't see the Q&A while I was speaking, so I'm glad you mentioned starting with staff. It's so important. It's one of the key lessons that we've learned. We are not, this is not an us and them issue. We are all experiencing trauma in some way in our lives, and definitely have seen a very high rates of violence and trauma among staff on the domestic violence side, as well as on the healthcare side. So that's absolutely critical. And the second place I would start is building those partnerships between the community-based program and the healthcare program. beginning with that, and we can help you find your local program. We can point you to where you can find them, and even when you don't have somewhere local, if you're in a rural or remote area, how to connect up at with the hotline or others. So building that up as a starting place is a really critical component. And then I would just say practicing, just diving in. Once you've done that research around your partnerships, you've done a little thinking and training, just as what we lifted through, going ahead and diving in and practicing with this universal education. And I've really found just diving in, like with everything, it's how you best learn and understand what your patients and clients need both. Liz, would you add anything more to that?
That was it, and I will just say that the feedback that we have gotten in the context of research as well as practice is that our patients really appreciate this approach. And even more, our providers are like, this totally makes sense. This is feels so much better. And I think in many ways, for our health professionals who got into this work because we care so much about healing and recovery and our role as healers, that really helps us get back to that place of having conversations with our patients. And we have actually like timed this out. It takes less than 10 seconds to do in terms of a universal education approach. I actually think it's faster than the screening questions. And so in many ways, our practitioners think when they feel supported, right, by the health system with those partnership agreements in place, with a lot of staff support and a recognition that intimate partner violence touches all of us, that we are really starting to transform our systems to what I call healing centered systems.
Thank you so, so much to both of you for all that you have shared today. I am really looking forward to part two, where we'll continue the conversation on Tuesday, December 3rd. If folks tuned in today, please do take a moment to register for that if you haven't already. And meanwhile, we'll look forward to getting this fabulous information and the slides out to you. Thank you all so much.
Thank you so much.